things like that, okay? So if somebody's got like, they come in during the winter and they've got their, fuzzy hoodie on and stuff like that, and you can't really feel where the joint line is, you need to at least get that arm out of there, if they're freezing cold and they don't want to take the whole thing off, but you need to at least get that arm out of there and have, them appropriately positioned so that you can find out what you're doing if you're doing it effectively, okay? And then also just, make sure the patient, understands what you're doing so they're not freaked out. Just say, hey, we're going to improve your joint mobility so you get some more motion. Okay. Let's see. So what we're going to do today is we're going to do 2 different mobilizations. First, we'll do the glenohumeral joint, okay, which is a convex on a concave surface, okay? So you've got your convex humeral head moving on your concave scapula, okay? So the roll and glide are in the opposite direction, okay? So the one I'm going to show tonight is an inferior glide, and I'll have Jason come up and lie down over here, okay? So an inferior glide, if I'm gliding the joint inferior, which means I'm pushing it down, which motion am I trying to improve? It would be the opposite of me moving my arm down, which is abduction, okay? So does that help, Ivana, a little bit?
Not yet.
So if I am going to glide down, I'm going to improve the motion in the opposite direction, which is into abduction, okay? So roll and glide opposite. Does that help you guys make sense a little bit? All right. So we stick with that one. Then, because I am
Table can't move because it's bolted down, and Sarah's slightly immobile. If you guys need to get up and move around and see, please do.
I'm going to come over on this side, but yeah, if I am in your way and you cannot see me, just, please let me know, okay? All right. So, ideally, when you do joint mobilizations, okay, the patient should be at where they're restricted. So if they can move their arm to here, you usually want to place them in the end of their available range. That's not a closed pec position. So if I'm done up here, I'm probably not going to be joint mobbing them because guess what? They don't need a joint mob, okay? So it's usually the end of their available motion. Just for today, for practice sake, we're going to kind of do it in more of an open pack position, okay? So the open pack position of the shoulder is about here. You can bring them up a little bit easier here if you want to just kind of hold them around this area. It's a pretty open pack position of the shoulder. It's going to feel easiest to mold them in this position, okay? So ideally, it's always applied at the end of the available motion if you really want to gain motion. If you're doing it more for pain, you can apply it anywhere along that line, okay? The main thing that you want to do first is you want to find out where their joint line is, okay? Because we always have to glide. Our glide has to be performed parallel to the joint. If you think about it, if I'm not performing that glide parallel to the joint surfaces, what am I doing? I'm kind of causing some compression, right? I mean, I'm going to be jamming one surface with the other. It's not going to feel very good for a patient, and it's not going to be very effective, okay? So if I look at the glenohumeral joint, remember, as my motion changes, the angle of his joint changes a little bit, okay? Do you guys appreciate that? Okay, so if I'm here, I'm going to be moving in a slightly different direction than if I'm down here. I'm going to be moving more here, okay? So I just have to either expose the joint if I can't feel it, but you can just kind of roll right off that acromion here, and you're right on that humeral head. That's kind of how you can feel it the easiest, okay? You have any problems with your shoulder? No? I should know about it. Yeah. So, you want to find that because you always want to apply that glide parallel to it, okay? Then remember, before I do that, I want to apply a slight traction force, okay? So usually what I do is you want to get your hands as close to the joint as possible when you're mobilizing. So I'm going to come in here underneath his axle and his armpit. I'm going to say, scoot your body this way, come visit me. And usually I hate these big pillows. In my clinic, I take these pillows and I put them underneath the table, and we've got these nice little flattened cervical pillows that I just use. Because if I've got his head jacked up here, that's going to influence his neck motion and his shoulder motion too. So you got a patient resting in a whole bunch of shoulder, or scapular cervical protraction, you're going to maybe be causing some pinching of the joint too. So I get that pillow out of the way, at least if you only got these big pillows. Make sense? Okay. So I'm going to look at joint alignment. I'm going to get myself appropriately aligned. I'm going to get close to the axilla. I'm going to do a little bit of joint traction. It's just separating the joint surfaces so I can make it easier to glide. Okay? Then I'm going to apply my glide. I'm going to go in an inferior direction. Okay? and it's done with my body. So if I move like this all day with my hand, that's great. You know, my shoulder's going to wear it out after a while. So the mobilization, I get myself in a good stance, I get appropriate version, and then it's through the body. Okay? So this is a joint mobilization. I'm doing an inferior glide. This is about a grade 2, maybe grade 3. Okay? Feel okay? Usually it doesn't feel like much if you don't, yeah. Or you can tell them, okay. But usually it's just kind of like you might feel a little bit of an oscillation going on, but usually it shouldn't be painful. It should, a lot of times it's kind of fairly comfortable for a patient. Sometimes I do this on a patient just when I'm assessing joint mobility and their initial eval, and they're like, oh, that feels good. You know, so, hey, guess what? You know, you're not in doing the initial eval, but maybe your PT will pick up on that and go, I think this might help them, okay? Any questions on that?
So right before you did the glide, was that contraction? Wasn't it distraction?
Well, it is a distraction, yes. And I think, Tim, let you go. Last year, what we do is, you can let your arm drop, I still got it, unless you want it back here. Oh, back to you. So you have to feel like you have to hold it out there. Yes, technically, the technical term for a distraction is the separation at the 90-degree angle, okay? So that is a distraction. And this is a long axis traction. In the clinical setting, we kind of use traction and distraction interchangeably. Usually, if I'm just kind of pulling the joint surfaces apart, we call it, I'm tractioning them. So yes, I don't know where Tim went, but I'll ask him, because I don't know if he's going to ask you ever on a test. I don't think he'll ever ask you on a test if there's a difference, but yes, when we do actually do shoulder lab mobilization, we teach you both a traction, a long axis traction mobilization, and a distraction. So that is the time when you need to know the difference. But in the clinic, if I'm just separating joint surfaces, I might call it a distraction, I might call it a traction. So that's just because I've been a PT for so long that I don't say distraction anymore. We just say I'm pulling apart and tractioning it. Does that make sense? So there are two things. If I'm talking specifically about that 90 degree, that is, yes, technically a distraction of what I'm doing. But we just kind of interchangeably. Hey, Tim?
Yes.
I'm sorry. I knew this would happen when you said it. But the distraction versus traction, I'm explaining to them that, yes, there is a difference. When we do shoulder lab, we need you to know that the distraction is at that 90-degree angle, and the joint traction, or the traction is a long axis traction, where it's applied purely. But I said, in a clinical setting as PTs, we sometimes call this just tractioning the joint, is that separating the joint surfaces.
So distraction is if we take the joint in its open pack position and we move those two joint surfaces apart at a right angle. Okay? Whereas if I do this and I apply this force, I can apply a long axis traction, and it's not necessarily a distraction.
But basically, I was just saying, I'm going to, you know, apply a traction here before I do it. Because in a clinic setting, like, you know, we just usually use it interchangeably. So I just wanted to clarify that, how you would like it in a clinic. I said, yes, if we're going to test you on the shoulder, and we're going to test you on a long axis traction, we want you to know, and I want you to call this a distraction, but in the physical therapy world, you're going to hear people just saying, I'm tractioning
Traction,
the joint.
which means they're kind of just
I'm just
pulling that
separating the
apart.
joint surfaces.
Separating the joint
I'm
surfaces.
technically doing a distraction, technically by the term and the definition of it, but we call it a traction.
Okay.
Does that help you guys? I hope that's not more confusing, but it's just that's the, you know, we shorten it up like Easton if people hook up electrical stimulation. Nobody really says, I'm gonna, you know, would you like electrical stimulation? You kind of go, do you want a stim or, you know, that type of stuff. Okay? It's a little slang. Yes?